Electrocardiogram ECG is used to record the electrical activity of the heart from the different angles. You know that the heart consists of the muscles and the electrical fibers like the SA node, AV node, bundle of His, right and left bundle branches, and the Purkinje fibers. These are the electrical signal travel in these muscles and these electrical fibers, and this electrical activity is picked up by the ECG machine and is shown on the ECG paper like this in the waveforms. This is the graphical representations. And okay, ECG lead, when it is very important. ECG lead is a graphical representation of the heart electrical activity generated from several electrodes. This graphical representation is called, these are the ECG leads. Now ECG conventions. So when you pick up the ECG paper, you will see two types of squares. This one is the large square and these are the small square. Each large square consists of 5 small squares, okay, in one row, and 5 small square in the one column. Now we see in the ECG paper, we see the distance, times, and the voltage of the electrical activity. So distance is present in the horizontal and the vertical and horizontal, and the time is present in the horizontal line. Voltage is present in the vertical line. Now what is the paper speed? It is the 25 millimeter per second. In 1 second the ECG machine print 25 millimeter of the paper. Okay, now when you pick up the ECG paper, it is mostly of the 10 second, and in this 10 second you will find 5 large squares. Okay, now if 5 large squares are equal to 10 seconds, then one large square will be equal to 0.2 second, and each small square will be equal to 0.04 second. Divide this by 5. Now the distance, each large square is equal to 5 millimeter. This is one large square, so it is 5 millimeter horizontally and 5 millimeter vertically. Okay, and each small square is 1 millimeter. Divide 5 by 5, so it will give you 1 millimeter horizontal, 1 millimeter vertical. Now voltage, 2 large square is equal to 1 millivolt. So one large square will be equal to 0.5 millivolt. One large square is equal to 5 millimeter. 2 will be equal to 10 millimeter, and this 10 millimeter 2 large squares are equal to 1 millivolt. And this is the sensitivity of the ECG. Sensitivity is 10 millimeter equal to 1 millivolt, and the paper speed is 25 millimeter per second. And this should be present in each ECG, and you should check this before reading in ECG paper. Now how to read a 12 lead ECG. So remember, this mnemonic are for the heart rate, rhythm, P wave, width of the QRS complex, Q wave, ST segment, and T wave. Now details. When you pick up the ECG, first of all you have to read the details like the patient name, date, time. It is given in the bottom or above of the paper, and here it is given in the bottom. And one important thing is to see the speed. It should be 25 millimeter per second. Second is the heart rate. There are two methods. Normally we find out heart rate by palpating the radial artery, but from ECG you can find out by these two methods. Now if the rhythm is regular, mean the RR interval is regular, then use this method, RR interval. You see in this ECG the RR interval are the normal. There are 4 large boxes in each RR interval. So if this is regular, then use this method. So divide 300 by the number of large squares between RR interval. So if we take this RR interval, and it consists of the 1, 2, 3 and 4 large squares. So divide this by 4, so you will get 75 beats per minute. Now if the rhythm is irregular, like in this ECG, the rhythm is irregular, the RR interval are the not regular. So in this you use this method, QRS complexes. So count the number of QRS complexes on rhythm strip. So this is the rhythm strip. Like the rhythm strip mean then the leads take that lead which is present throughout the ECG paper. This one, So this paper is normally of 10 seconds, and QRS count the QRS complexes in this rhythm and divide this by the 6. So you will get the heart rate for the 1 minute. So if the beats are the greater than 100, so it is tachycardia. If less than 60, then it is bradycardia. Now what are the rhythm? You know that the SA node fire atria depolarized, then ventricle depolarized. So this is a normal rhythm. This is called sinus rhythm or the normal rhythm. So if the electrical activity start in the ventricle or atria rather than the SA node, it will be called arrhythmias. Okay, so then there are two types of arrhythmias: regularly irregular, irregularly irregular. So if the R interval are the not regular, you see here the number of large boxes between the R interval are the 4, 1, 2, 3, 4, and here it is greater than 4, so it is not regular, it is irregular. But if you see the RR interval or the number of large boxes between this R interval and this, the lower boxes are the regular, and here also the lower boxes are irregular. So there is some regularity, but here there is irregularity. So it is regularly irregular, and it is present in Morbus type 1. Second is irregularly irregular. Irregular means that the RR interval not regular here and here. This is the RR interval is not regular, and irregularly means that this regularity is present throughout the ECG paper. Like it is present, some regularity is present here but not here. Okay. Now cardiac rhythms. This is the ventricle, and the average current is shown by the average current is shown by this vector, this axis. It is normal, and it is normally at the 60 degree. Okay. Now if it should lie between the -30 and plus 60 degree, and this is the normal QRS complexes, normal QRS axis. But if this vector lies to the right of this 90 degree here, it will be called right axis deviation. If it is present here, it is called right axis deviation, and if it is here to the left above the 90, then it is called left axis deviation. Okay, so right axis deviation is present between plus 90 plus 180, plus 90 and plus 180, and left axis deviation is present -30 and -90. Okay, now normally when the axis is present in this range, the lead 1 is positive, lead 2 is positive, but lead 3 has some positive and negative deflection. But when the axis is present here in the right axis deviation, then this lead 1 become negative. Here it is become negative, and the lead 1 become negative, and the lead 2 is positive. Okay, so lead 1 become negative in the right axis deviation, and it mostly seen in the right ventricular hypertrophy. Now if this deviation become left axis deviation, then the third then the lead second and third become negative, because these deflection are the opposite of the normal. Okay, so that's why they become negative, and it become positive in the lead 1. So in left axis deviation, deflection is positive lead 1, negative in lead 2, and also lead 3, and it most commonly occur in the left ventricular hypertrophy or conduction abnormalities. Now the P waves. P waves represent atrial depolarization. So for the P wave, you have to see, are the P waves present, are the QRS complexes followed by each P wave. So you will see this in all the ECG leads. Do the P waves look normal, like duration, direction, and shape? These are the abnormality of the P wave. Like tall P waves, it will be seen if the atria is enlarged. So you will see this tall P wave because the muscle mass, the atrial muscle mass is greater. So, and second in the chaotic P waves, you see here the P waves are not like this normally. It is like a tiny spike. So these are the chaotic P waves, and it is seen in atrial fibrillation. Okay, now the sawtooth P waves, this appearance like a sawtooth, and it is seen in the atrial flutter. Okay, now if the P waves are absent, you see here there is no P waves, and this is mostly seen in the paroxysmal supraventricular tachycardia, AV block, sinus arrest, AFib, and flutter. They also cause absent PVOs. Now PR interval, it is the interval between the onset of the PVOs and the onset of the QRS. Normally the PR interval occupies five small square or one large square. One large square is equal to minus 0.2 second or 120 millisecond. This is normal. Okay, so when the PR interval is occupied by the greater than 5 small square, it will be called prolonged PR interval. Okay, and if it is occupied by the less than 5 small square, it will be called short PR interval. Prolonged PR interval is seen in the impaired AV nodal conduction. Anything which decreases the conduction in the AV node, PR interval will be prolonged. Okay, like beta blocker decrease AV conduction, MI, and the heart blocks. And short PR interval is seen in the old Parkinson-White syndrome. This is the PR interval is very short. Q waves are normally a very slight small negative deflection, but when it becomes very large, it shows that this patient has some previous myocardial infection. Previous myocardial infarction. Now the QRS complexes. Normally the QRS complexes is of the 3 small squares. 3 small square, 1 QRS complex. Okay, and 1 small square is equal to 0.04 second. So 3 will be equal to 0.12 second or the 120 millisecond. If it become greater than 0.1 second, it will be called prolonged QRS, and it is normally mostly seen in the bundle branch blocks, ventricular conduction delays. Anything that decrease conduction in the ventricles, the QR complex will be prolonged. Okay, such as the ventricular hypertrophy, the muscle mass is increased, so it will take longer for the QRS, for the muscle mass, for the ventricle to depolarize. It will show prolonged QRS complexes. Okay, similarly in the cardiomyopathy and MI, medication like antiarrhythmic, psychotic, and hyperkalemia also cause prolonged QRS milk. Now QRS amplitude, it is large in the left ventricular hypertrophy. This is normal QRS. This is prolonged. Now ST segment, it is very important. End of the QRS complex to beginning of the TVO. End of QRS, beginning of TVO, ST segment. Now you see this is the baseline, and QRS normally lie on the baseline. There is no deflection here, but when the ST segment is mostly lies on the baseline and there is no deflection. But if the ST segment is above the baseline, this is a baseline and it is above, like here see it is above, it is called ST segment elevation. ST segment elevation. Okay, it is called ST segment elevation. But if it is below this baseline, like you see this is baseline and this ST segment is below the baseline, so it will be called ST segment depression. So mostly ST segment elevation is seen in the MI. MI shows ST segment elevation. But if this ST segment elevation is seen in lead 1 to 4, like here it is interior MI, 1, 2, 3, here also elevated, also elevated, so it is interior MI. If this is seen in the lead 1, ABL, V5, V6, it will be called lateral MI. Like this is the V1, this is the ABL, this is the V5, V6. But if it is seen in lead 2, 3 and AVF, it will be called inferior MI. Like this is 2, 3, AVF, inferior wall MI. But if this ST segment elevation is seen in all leads, it will be called diffuse, and it is seen in ST pericarditis. ST segment depression is seen in MI, ischemia or infarction. Now the last one is T wave inversion. Normally T wave is a positive deflection, as you see here, but when it becomes negative below the baseline, it is called T wave inversion. And it is mostly seen in MI or infarction, myocardial ischemia or infarction. Also electrolyte disturbances like hypokalemia or pericarditis. You see this patient has MI in lead 2, lead 3 and AVF, so it is the inferior wall MI. inferior. Now in summary, if you pick up the ECG paper by patient, first of all you have to check for the detail of the patient, then the heart rate, rhythm, P wave, QRS complex, Q wave, ST segment, and T wave inversion. So this was all about the ECG. If you have any query, please ask in the comment.